Hello, everyone. This is Dr. Susan Hudson from Texas Fertility Center with another episode of Fertility Docs Uncensored. I am here with my fantabulous, smashing co-host, Dr. Carrie Bedient from Fertility Center of Las Vegas,
Hello.
and Dr. Abby Eblen from Nashville Fertility Center.
Hey, everybody.
And we are so excited to have Lindsey Lusson. She is a registered dietitian, and her practice is food, freedom, fertility. And she knows everything we want to know about nutrition and exercise and fertility and how those things interact. And we're just so excited to have you on the show today.
Yes, well, thanks for having me. I'm a big fan of the podcast, so it's fun to get to come on and get to be a guest.
So we were talking a little bit earlier that you and I actually both went to Texas A&M.
Correct. Yes.
That's awesome. That's awesome. And we always record a little bit ahead of time. And right now there's some big Aggie athletic stuff going on. And you used to work for the athletics department.
I did. Yeah. So, I think I kind of started. So, I'm a registered dietitian, and originally I thought I wanted to be a sports dietitian working with collegiate and professional athletes. So only made sense that in order to kind of get in that realm, to be working, I worked beneath our sports dietitian at Texas A&M, Amy Bragg, who I believe is still at Alabama now. But anyways, yes, we got to do some really cool things. It was funny because I was getting paid minimum wage, which way back when was like $5.75 an hour, but
But you loved it.
Yeah, I loved it. And we got to like make trail mix for the athletes. So we'd like deliver to the baseball fields, pack snacks for them. We got to do some pretty cool things too, running DEXA body scans, looking at bone mass, looking at muscle mass, body fat percentage, things like that. So really, we're honestly like such a cool job. I did eventually kind of take a segue and decide that working in sports dietetics wasn't for me, although I definitely still use the knowledge and expertise that I had from that job, even in my private practice today.
That's so cool.
Were you an athlete in college as well? Like, is that where the original sports interest originated?
No, I think that I got very into just like fitness and nutrition right into college. I never actually was an athlete. My past Division I athlete husband reminds me that all the time, that I never was the athlete. But I kind of like went back and forth. Do I want to major in nutrition? Do I want to major in kinesiology? Kind of ended up doing both, getting my master's in exercise and sports nutrition. So I've just always kind of had a passion for fueling appropriately for people, athletes and people who have like high energy needs.
So how do you do that? How do you figure out what the average person needs versus like when you worked at Texas A&M? What do athletes need differently that are D1 athletes?
Yeah, for sure. Well, a lot of times you have to think about, especially like collegiate athletes, it's not only their sport, but also they're walking around like Texas A&M, a gigantic campus. And so their energy needs are going to be a lot higher than somebody who's sedentary or even somebody who's not a student. Also, to think about somebody who's like 18, 19, 20, 22, they might still be growing. So probably like some of the highest energy needs of any individuals, but in particular, athletes are going to need more protein. So a lot of times we talk about how just the general population kind of needs about 0.8 to 1 gram per kilogram body weight of protein just to kind of maintain normal body mass. Athletes are typically needing anywhere from 1.5 to 1.7, all the way up to about, I think 1.75 or 1.8 gram per kilogram body weight is usually where we kind of tap out on seeing the benefits for muscle gains and maintaining muscle mass. So they're going to need more overall calories and energy, more protein, and probably the one that honestly, what I notice, especially in women who are under fueling, the one that falls by the wayside a lot is carbohydrates. A lot of times people just kind of think that, I think it's just kind of more of a villainized food in the culture.
It is, yeah.
For sure. So I think that that's the one that people really forget about. And especially when we talk about how our brains need a certain amount of glucose to function optimally. And then athletes just expending a lot of energy going over and above, they really do need more carbohydrates than somebody who's sedentary or
quick
more
energy.
Yeah.
Good stuff. Let's do a question real quick. And we actually have an exercise related question. I was so excited when I found out we were going to be talking today because this one popped up recently and I was like, oh, it's perfect for Lindsey. Okay. So here's our question. My wife is exercise dependent. She was a college athlete in 2022. She was running up to 90 miles a week on a low calorie diet.
Whoa.
She had
That's a lot.
triad. We started our fertility journey in fall of 2022. It began by increasing her caloric intake and reducing the running. At this point, her body reacted very poorly. She became bloated and gained weight quickly and struggled mentally. In 2023, she ended up steadying out her running around 35 to 40 miles a week and maybe eats 2,500 calories a day. This is impacting our marriage. We won't see a counselor. She won't see a counselor. We have tried fertility injections 4 times and are now mid IVF, but she's still insistent on running, spinning, or hot yoga despite doctor recommendations. I don't know where to go from here. There's a lot in that.
A
And
lot.
so do you want to touch on some of those things currently or kind of lead this into our discussion?
Yeah, either one. I mean, I want to first just say that like I see this a lot in the people that I work with, and it's not going to have a straightforward answer about exactly what to do. As I think you're kind of alluding to, there's a lot of layers that we might have to peel back to find the right next step for this individual.
Right. Good stuff. Well, let's start off with exercise, trying to get pregnant. What's good? What's not good? What are some things we need to be thinking about?
Yeah, for sure. I mean, first and foremost, like exercise is important for fertility, and mainly just with the fact that it can be helpful for if somebody has a condition like PCOS, it can be helpful for lowering insulin resistance. In fact, a single bout of exercise can lower insulin sensitivity for up to 16 hours. So we see a lot of benefits with exercise alone, even when we're not talking about changing diet, even when we're not talking about weight loss. Exercise alone can improve insulin resistance, and therefore with somebody with PCOS can help them to ovulate more regularly. So huge benefit there. On the male side of fertility, significant, we see increases in sperm count, motility, and morphology. If somebody's kind of not exercising at all, and then they start to exercise after about 16 weeks, we see changes in those parameters. So benefits for men as well. And just exercise in general kind of has a anti-inflammatory, antioxidant impact. So it can help with decreasing inflammation, which can be tied to kind of a slew of different fertility issues. So exercise is important, but it is kind of like this Goldilocks scenario. We want some, but we don't want too much. And there is
that's a good analogy.
too much exercise, especially in the context of fertility.
So what are some examples of too much versus maybe some goals we should attain?
Yeah. Well, some of this is going to be person dependent. So I'm sure you guys have seen these patients, or maybe you don't see these patients because these are the people that are having no issues getting pregnant. So therefore they're not needing to see a reproductive endocrinologist. But we all know of women that can run marathons and train for 100-mile races and like pop babies out like it's their job, right? Like everyone's going to be a little bit different here. But what we do know is about 50% of active women do struggle with menstrual irregularities. These aren't always typically very obvious to people until they're paying attention and maybe trying to get pregnant. So about 50% of women can experience kind of low level under fueling issues that can show up in their cycle. So for instance, somebody might be getting their period pretty regularly, but they're not ovulating regularly, or they might be getting their period, or they might be confirming ovulation, but then getting their period like 5 to 7 days later. So they have a short luteal phase, low progesterone. So those are kind of a lot more common. And then about 30% of active women can experience hypothalamic amenorrhea, which I know you guys have talked about on the podcast before, but kind of total period loss, no period at all, related to kind of the mismatch between what they're taking in calorically through food and what they're expending through exercise, in combination with probably some degree of some psychological stress as well.
So I know there's really no norm. It's hard to put everybody in a box, but I find it's really interesting when I talk to people sometimes that are really heavy, and when I talk to some people who are really thin and very athletic. Both sort of interestingly enough, sometimes have this sort of the same mindset. Like they think what they're doing is what everybody else is, what the norm is. So why would this impact their fertility? And so could you give us just some general parameters for an average sized woman? What's a normal amount of activity? How many hours should you be running? What kind of intensity? How should you be eating because of that?
Yeah. Well, I think that, so whenever somebody talks about like exercise guidelines for general health, my default is to go back to American College of Sports Medicine, ACSM guidelines, which is about 150 minutes per week of moderate intensity exercise or 75 minutes per week of vigorous exercise. So what that kind of looks like broken down, moderate could be anything from like Pilates to walking to, kind of walk, run, interval training, and then vigorous being more like high intensity interval classes, F45, Orange Theory Fitness. I know that those are really big popular ones.
Yeah, hit.
Of my really intense exercising clients. Yeah.
It's interesting that you say only 75 minutes of that.
I was thinking that too. That's
not very much.
I have a lot of people who are doing 75 minutes easily in 2 days, much less in a whole week.
Yeah, me too.
Yeah. Yeah. Well, and like, with guidelines, right? There's going to be people that can venture outside those guidelines and be totally fine. Really what I've noticed in the literature and in my practice of what it kind of comes down to is two things. Number one, genetics. So some people are genetically more sensitive to having irregularities in their cycles, having an impact their fertility. Some people are genetically more sensitive to period loss. In fact, in some kind of genetic studies, we've seen linkage between women with hypothalamic amenorrhea sharing genes with women who experience kind of more like idiopathic reasons for never starting a period or like primary amenorrhea. So some people are just more sensitive there and can't get away with as much as somebody who maybe has some scrappier genes. The other biggie though is fueling. So a lot of times women that are exercising at that intensity either don't know how to fuel for it. So in a lot of like our athlete clients will just kind of notice like people could like scrape by on the bare minimum and perform pretty well in their 20s. And then in their 30s, they're noticing that they don't have a period at all, or they have really light periods. And so it can be a knowledge deficit. And then unfortunately, the other side of it is a lot of women are exercising that much or at that intensity to try to maintain a body size and a body fat percentage that may not be healthy for that individual.
You mentioned carb. Go ahead, Carrie.
Oh, I was going to say, kind of in a slightly different vein, when we have patients who have irregular periods, sometimes our heavier patients where we're looking at more of a PCOS type picture than a functional hypothalamic picture. So there's dysregulation on part of the gonadotropins, the brain signals to the ovaries, but it's a different type of dysregulation.
Different mechanism, yeah.
Sometimes those patients will go into really intense exercise patterns and they will lose their cycles as well, but we're also actively trying to have them lose weight. And so it's a lot less clear of, okay, is this exercising too much? Are we putting a deficit where we shouldn't be? Or is this serving our goal of she needs to lose weight because that's going to make it more likely that her natural capacity to ovulate is going to return? How do you balance exercise in someone who's carrying extra weight rather than is not fueling enough, doesn't have enough, body fat storage to cover themselves?
Yeah, definitely. I think in the context of fertility, and PCOS isn't 100% my wheelhouse, but I'm enough in like the fertility niche and conditions like that to kind of speak a little bit to this. With PCOS, we also don't really want to be stressing the body out because there's kind of the adrenal component of PCOS and elevated androgens. And sometimes if somebody is exercising intensely and they're trying to lose weight, so they're in a calorie deficit, which can raise cortisol levels, and they're doing, high intensity interval training, which is also raising cortisol levels. Sometimes that could be counterproductive, not only for weight loss, but for regular kind of hormone balance and fertility. I've definitely seen people who present more like PCOS, but also have a layer of HA on top of that, in which case it's tricky because we have, especially if there happens to be like some disordered eating or something going on, we kind of have to address that first and then see and then kind of give the body some time to kind of course correct hormonally. And it's kind of a long game thing, but first and foremost, somebody's mental health really matters. So we want to make sure that they have a steady relationship with food and their body, that they're able to fuel appropriately. But to kind of circle back to your original question, Carrie, you can still exercise. So usually like with those type of people, we're talking about doing things like Pilates, kind of walking, slower, kind of moderate intensity type exercise, not like things that are going to stress your body out even more, especially if there's a stress component to PCOS.
Can you speak a little bit more about the breakdown? You talk about a calorie deficit and disordered eating. Kind of talk a little bit about, like, if somebody asked me that specific question, like how much protein should I have? How much carbohydrate? How much fat? Can you kind of break that down a little bit for the average person, just to give us a sense for what you should be getting?
Yeah, I mean, for my clients that I'm working with that have no period at all, we're trying to actually get them into calorie surplus. That's a really important part. And to maybe even kind of circle back to the question at the beginning that we talked about is, for people who have no cycle at all, it's really important that we don't just give them enough energy, but we're actually getting them into a surplus to help the body to kind of trust that it has extra energy. I mean, we think about how energy cost of ovulation is. We think about how energy cost of it is to make a baby, grow a baby in your body for, So it's about helping the body really feel safe and to really reestablish that trust. So it's going to take a lot of food to get somebody's cycle back. For general fertility, I do find that a lot of women are under eating, and maybe not even under eating like within a 24-hour period, but we do see a lot of women who are like waking up and downing coffee and like eating this light little salad for lunch. And then like, oh, well, now it's 4 o'clock, so I might as well power through until dinner. And then they might take in the bulk of their energy at the end of the day. So maybe like calorically, they are eating enough, but they've been kind of been in this energy deficit, which can be really stressful on the body all day long.
Do you find, I know sometimes we have patients who come in and they have always historically been, and I'm going to say too thin, okay, like BMIs of, 15,
20.
16, like not like healthy thin, but they walk in and when I glance at them, I think eating disorder. Okay. They decline any history of that. And it's just like, this is the way I've always been. Everybody's always been worried about it. And like, I go through the entire fertility evaluation and I have nothing else except I'm like, there's not enough of you to fuel a growing human. Like, I know that is an issue. How do you address those types of things?
Well, I think it's really important as providers that we are properly screening for eating disorders and making appropriate referrals when possible. So if you have somebody who is fitting clinical criteria for something like anorexia, it's important that you're getting them in touch with a whole treatment team, a psychologist, a registered dietitian, an overseeing physician who's eating disorder informed. Unfortunately, eating disorders can be very convincing in helping you in making you think, I'm not that sick. It's not that she's thinner than me. Why does this have to happen to me? And so, I mean, it takes a high level of support, but it also takes a patient that's kind of willing and ready to start doing the work. I do find that fertility is a really great time for someone to get a little bit more serious about, healing from an eating disorder. Because I think a lot of times people think that it doesn't impact anyone but them. And this is fine because this is just how I've always been. And this is just how I operate. And then whenever they start thinking about starting their family, it's about them and their partner. It's about
a good motivator.
Yeah, for sure. It can be a really, really, really good motivator. I've seen a lot of really beautiful, healthy transformations in people healing from eating disorders and being able to become moms still.
How do you handle a lot of the bargaining that happens? I mean, I feel like with the patient that Susan described, she comes in and we'll go into some of that history and I'm thinking about a patient from several years ago where she said, I exercise 3 hours a day, and her BMI was, I mean, you could see every muscle. She was very, very fit. There was absolutely no body fat, and she exercised 3 hours a day. And I told her, okay, we need to start cutting back on that and eating forward and eating more in order to move your progress forward. And she came back a couple weeks later and was so proud of herself because she cut down to 2 hours and 40 minutes. And that was an excellent progress, but it was nowhere near what we needed to do. And she's very technical. She's very smart. And she wanted to know, well, how many calories can I expend? What do I need to eat? I mean, she
wanted, is this going to reverse?
Very, very specific numbers so that she could keep doing the max of what she wanted to be doing without any less.
Yeah. I mean, I think you have to get really honest with people and start asking questions about, like, why are we exercising so much? What is the end goal? And if somebody's an athlete, because we definitely work with people that don't have eating disorders, they just love to exercise.
Athletes.
It's okay.
Yeah.
Unfortunately, I think that for fertility, sometimes you have to put your training goals on the back burner to accomplish your goal of becoming a mom. And that's okay because exercise will always be there. And we've definitely helped clients get back to exercise, training, running marathons, and doing all those things as a mom. But unfortunately, I will get really honest with people and I'll be like, these are conflicting goals. If you want to exercise for 3 hours a day, or do you want to exercise for 3 hours per day? Also, why are we exercising so much? Like, what's going on? Like, what are we trying to get out of it? What are we running from? What are we escaping from? What kind of fears do we might have about body image stuff going on? Yeah. And then thinking about like, do we want to continue to do that? Or are we ready to become a mom? Because I don't see those. Of course, they can coexist for some people, right? And again, these might be not the people that end up in your office. But yeah, sometimes it takes an honest conversation about like, hey, this is a conflicting goal, and what do we really want to work towards? And to your point, Carrie, like for some people, the gradual cut down just isn't going to work. Some people are going to have to kind of flip a switch and be like, I don't want to say cold turkey, not exercise at all, because of course, mental health matters. We already talked a little bit about the benefits of exercise for fertility. But yeah, to your point, like going from 3 hours to 2 hours and 45 minutes, like we're not, like the body's not going to respond with like just that tiny change.
I used to kind of prescribe and tell people like, well, you need to maybe do this, instead of doing this intensity of exercise, do that intensity, and, kind of giving them some parameters. And then people would always kind of fight that, like, well, but what about this? And finally, now what I say, I don't really know what it's going to take to get you to ovulate, but it's not me, it's your body telling us that you don't have enough calories to generate an egg and make an embryo. And until you start taking in more calories and exercising less, that's just not going to happen. And it's different for every person. So I don't know, so they tend to take that better because it's not me they're angry at.
Do you have any advice on when we're looking at different types of exercise, whether it's cardio or weightlifting or like
Swimming,
water sports? Like what are things that work well when somebody's trying to conceive, whether they're, if they're trying to just get their body in a better condition to support pregnancy, or if they're overweight? What are kind of some balance mechanisms and different types of exercise you would advise?
So typically the types of exercise that are going to raise cortisol levels the most are going to be your high intensity interval training, in particular, like sprint training, going back to, and not to like completely drag people's names through the mud that run fitness studios, but like, if somebody's doing something like Orange Theory Fitness, which is a high intensity interval training class, and they're doing it for 60 minutes, 4 to 5 times per week, that is really, really stressful on the body. Can a 25-year-old who's not trying to get pregnant get away with that and be perfectly fine and healthy? Yes, 100%. But in the context of fertility, and I always kind of like to remind people too, is it's not just that like the stress from the exercise is the worst thing, it's impacting your fertility. It's almost that it's just adding to your stress bucket. So again, somebody who's 25, living their life, traveling, very low stress, they can probably get away with that and have healthier hormonal balance, healthier, likelihood of fertility, versus somebody who's 35 in a high stress job, maybe in a stressful relationship, maybe just moved cross country, isn't sleeping well, isn't making time to nourish well, and she's training like that. It's just like her stress bucket is full and overflowing. So it'll be a little bit person dependent, but in general, kind of those high intensity running, very heavy weightlifting, high intensity interval training classes are typically not the best, just kind of thinking about general guidelines for fertility, but doing things that are kind of low or moderate intensity. And I really like variety. So like if you love your Orange Theory Fitness class, or your F45 class, like let's do that on Monday or Friday. Like that's a one time a weeker. And then we're going to do some reformer Pilates. We're going to do some gentle walks around the neighborhood. We're going to do some light cycling, a light, 20 to 30 minute Peloton ride or something like that. So kind of mixing up the variety can be really helpful too. That way we're not just over stressing the body day in, day out on top of maybe some other stressors that we have going on.
I think it's an important point that you're saying that both physical and mental stress, those are both going in the same
contribute.
bucket.
Right,
And
correct. Because the body really can't distinguish between the two. You know, we're not in the middle of a world war or a famine, but if you're eating a very low calorie diet and you're exercising 7 days a week for 90 minutes, your body doesn't know that you're not. So it's going to respond like it is.
very good
One
point.
thing that's probably helpful to point out to our patients is, in addition to the goals of getting you to ovulate, support a pregnancy, particularly when you're in the midst of treatment like an IVF cycle where your ovaries are expanded considerably more than they are at baseline, we don't want you doing a lot of this exercising and bouncing up and down and, lifting weights where you're using a lot of core strength and stability to do that, because that's how people start to have bleeding after a cycle, or they have torsion. And when I say bleeding, I mean internal bleeding, not vaginal bleeding. And so those are things that can make us have to take you to the operating room to fix it. And a lot of times that will lose people an ovary, because especially after a retrieval, it's really hard to stop that bleeding. And so some of the advice we're giving is based on, hey, let's support your pregnancy. Some of it is also, hey, let's not cause a complication that we could have otherwise really pretty easily avoided, that could really actively, immediately impair your fertility with the loss of an ovary.
What are some of your advices about like hydration? I know when we have patients who go through IVF, all that fluid that's going in those follicles to grow them, it comes from water. You're taking it in. So what kinds of advice do you give your clients about hydration when they're thinking about babies?
Yeah, I mean, hydration is pretty important. I mean, we think about like cervical mucus and cervical fluid being primarily water. Hydration status really matters. So if you're an active woman, you also need to be thinking about, you need even more than that. There really isn't an official recommendation for hydration for each person. I think the Institute of Medicine says aiming for like I think that they say 1 pound per, or 1 ounce per pound body weight. How that doesn't always translate for people. You think about somebody who's sedentary behind a desk all day, like maybe they don't need that much water, especially if they are in a larger body, versus somebody who's exercising every day, especially outside in a hot, humid climate. So what I usually tell people actually is just to monitor their color of urine. So what we're aiming for is light like lemonade, not dark like apple juice. And so kind of paying attention to that is really going to be the best indicator of how hydrated your individual body is.
Could you speak to men and nutrition and exercise? I had a guy this week, and it's always interesting. We're fortunate because we have usually a lot of time both partners. And so one partner will tell on the other partner. And because again, a lot of people sort of don't realize that what they're doing is really a lot of. So I had a guy this week who ran about 40 miles a week, and he had fathered a child before, and when we got his sperm count back, it was pretty low, and he was a really thin looking guy too. So he didn't have any, like, he was just totally dumbfounded when I said, I think it may have something to do with your exercise. And so can you speak a little bit to that?
Yeah, so it's really interesting. I don't think that this even gets as much attention as the female side of it, but we can have a very similar case of FHA, functional hypothalamic amenorrhea, in men. It's just not as obvious because men don't have periods. So
That's right.
In some ways, females are lucky because we kind of get that monthly report card. I mean, if your period something's up, stress, nutrition, sleep, etc. For men, it's kind of like, I don't really know. But there is a condition known as relative energy deficit in sport, which is quite literally the idea that you aren't taking in enough calorically to support just your basic metabolic demands, let alone performance in exercise. And some of the kind of warning signs of RED-S, relative energy deficit in sports, sometimes people call it REDS or RED-S, are low libido. Really
never heard that before.
Yeah. RED-S or REDS. It's really popular in kind of like the athlete realm, but kind of coming a little bit more mainstream. But a lot of the kind of symptoms are pretty similar to what we see in FHA in women. So like low libido, feeling cold in the extremities, digestive dysfunction. And this is one that I feel like people really struggle to make the connection. But our bodies actually need adequate amounts of fuel to regularly move food and waste through the digestive tract. So a lot of times women that are under fueling and over exercising are also struggling with a slew of digestive issues simply because their body doesn't have energy correct.
Ah,
To
interesting.
function properly. So we see a lot of digestive issues in men that are experiencing kind of low energy availability or RED-S, erectile dysfunction, mood changes, and then also too, we start to kind of see that disordered, problematic relationship with food and exercise, or food body image issues as well, with some of the underfueling stuff. And it can have a trickle down effect on their hormones, which can impact their sperm count, motility, morphology, et cetera.
Just to add the opposite end, just like in women who have obesity, men who have obesity also have a huge propensity to having infertility issues, because realize that your fat tissue does produce a form of estrogen. That estrogen counteracts testosterone, and that endogenous testosterone, the testosterone that's made within your body, not from injections, pills, pellets, however you want to get it, but that endogenous testosterone is important for sperm production. So, there really are those two extremes in both genders that we have to be aware of, and making sure that we're having physiologic balance.
What do you think about when someone needs to increase their caloric intake? And that can be hard in and of itself, just because of the amount of time it takes and the amount of energy it takes. And so everybody knows, okay, we're trying to avoid processed foods and all of those things. But when you're just trying to physically increase the amount you are eating, and you can only eat so many handfuls of nuts and fruits, not necessarily
avocado.
Yeah, like there's only so many avocados and almonds you can eat. How do you tell people, like, what kind of things do you consider, like, okay, if you can just grab one, I don't know, energy bar or this type of food, what do you tell people to go for that
What are
are
good high
things that they
calorie
can
foods
do?
that are going to be fertility friendly?
Yeah. So nuts and seeds are really helpful, especially if you're blending them down and putting them in something like a smoothie. I mean, you can pack thousands of calories into a smoothie and you can drink it down and not even really notice. So that's another thing that we work a lot on with clients, is helping them to maximize the energy that they're taking in while reducing the volume. Because to your point, Carrie, like if trying to eat, 2,500, 3,000 calories worth of broccoli, like they're never going to get there. And it's going to be a miserable experience because there's so much volume and there's so much fiber in this. So yes, it's kind of striking the right balance between, not just eating like Cheetos and ice cream all day long to try to meet calorie goals. But for some people too, we do kind of have to switch from like, super high calorie quinoa to like a white rice, just to not overtax their digestive system. But some of those quick go-tos, nuts and seeds, trail mix is a popular one. Peanut butter or nut butter, if you have an allergy, on literally anything and everything, on an apple, on toast, on, crackers, in your oatmeal, in a smoothie, etc. So, really focusing on healthy fats too, which are great for fertility, is a really great way to boost just your overall energy intake without, making you feel incredibly uncomfortable with taking in more volume.
Very good. Awesome. So Lindsey, kind of to wrap things up, what if you had a couple of words of advice for our listeners, and they're struggling with fertility and they're really wanting to figure out what are good resources for exercise and nutrition when they're living their daily lives?
Yeah, I mean, it's so hard because I feel like there's lots of great resources on social media, but there's also really horrible resources on social
media. What are the reliable ones on social media?
Yeah.
Besides your Instagram, which is Food Freedom and Fertility. Am I remembering that?
Yeah, food.freedom.fertility is my my Instagram and my TikTok if we have younger listeners. But I think you just have to really, like, before you go all in on believing something that somebody's saying on social media, is you kind of want to do a background check. Like, who is this person? What is their education? What is their credentials? Does what they're saying actually make sense? And does it apply to you? Because I think a lot of times people are taking general advice on social media. Like if somebody was coming to my page and they have PCOS, my advice may not be helpful for them for fertility. So kind of, thinking about, understanding that regardless of what somebody's saying, it may not apply to your individual situation. But doing a thorough background check on somebody's like credentials and education. There's a lot of really wonderful fertility dietitians that work in all different spaces. I feel like that's kind of a hot up and coming topic, because it's not something that a lot of registered dietitians, like I had to do a lot of additional education and kind of like self-funded trainings and things like that to kind of understand everything. But registered dietitians can be great, and in particular, people who kind of specialize in fertility. I think like first and foremost, you know, all the like information, books, podcasts, and et cetera are only going to get you so far. It might be like worth investing, like working with somebody who can really get a thorough understanding of your history, your individual situation, all of the lots of different things that can be going on that can be impacting your fertility journey, and assembling a team. So like a lot of times when we're working with clients, I want them to be working with a reproductive endocrinologist, because we can do all the things in the world, but if they want to be pregnant yesterday, we want to have somebody in our back pocket. We want somebody on our team that can run labs, that can rule out other things going on, that can prescribe medications to help kind of expedite and fill in some gaps too. So I always like kind of thinking about like assembling a care team of lots of different healthcare providers that can help you to get to your end goal of baby.
That's fantastic. Well, thank you so much for joining us. This has been fantastic. I always learn so much whenever we talk. So to our audience, thank you so much for listening, and be sure to tune in next week for more, and be sure to subscribe and leave us a review in Apple Podcasts. We'd love to hear from you. We're on Instagram, Facebook, and YouTube. Make sure you subscribe and stay updated on all things fertility.
You can also visit us on fertilitydocs.uncensored.com to submit specific questions. All questions will be answered on the podcast in our Ask the Doc segment, or even leave us an episode idea. We'd love to hear from you.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. Keep an eye out for our book coming out next year, and we will talk to y'all soon.
Bye.
Bye.